welcome to this event that's going to raise awareness for colorectal cancer in California. This event's sponsored by the American College of Gastroenterology, Dr. Sue here, Ron Sue, and the California Colorectal Cancer Coalition, where I'm the president of the board of directors. But I've had a lot of help from Margaret Hitchcock here, our vice president, and Mary Beth Kropp also, and she's here with another sponsor, the Fight Colorectal Cancer booth, which you can see right over there. It has the actual flags on it. So we don't like to talk about colorectal cancer, but these flags in front of you strung out in this portion represent the 5,530 Californians that are expected to die from colon cancer this year. And in Sacramento County, where we are, 611 residents are expected to get colon cancer, and 233 will die from colon cancer. So it's a real tragedy because screening for colorectal cancer is so effective. It reduces your chance of getting colorectal cancer and dying from colorectal cancer. If you're over 45, make sure you've been screened. Make sure your friends and relatives over the age of 45. When the school groups come through, we make sure they get their parents to get screened for colorectal cancer. So please have some popcorn. Visit all the booths that have been set up that can educate you about colorectal cancer. And, of course, go through the C4 colon. Screening does not have to be a colonoscopy. If you want, you can do a fecal test at home and do that yearly, or a large fecal test at home and do it every 3 years. And those tests are just as good as colonoscopy. The main thing is the screening test that gets done is the best test. So I want to turn it over to my other organizer and alter ego here, Dr. Sue. Ron.
Thank you. Thank you very much for coming, everybody. Yeah, so today's special event in Sacramento is called Light the Capital Blue. And the reason why we choose blue is because blue is the designated color for the National Colon Cancer Awareness Month, supposed to be in March. The reason why we're here in May is because you remember we had this big rainstorm. And thank you that we have ended our drought, but it put our event to today. Now, today we do not like the beam in Sacramento. We have the blue sky, lighting the blue, and we have 5,000 blue flags to light us blue, and then we all dress in blue. So this is the beginning of the blue. The message of the blue should be spelled out when you get home, and then get the message out. So the colon cancer is still one of the most common cause of cancer in the United States. It's like every 10 minutes that I speak here, there are 3 new cases, and 1 person died of colon cancer. It's so common. And we are going to spend some time to give you some messages and information. Today's program, we're going to have a few speakers to share with you some experiences and messages that what we're doing to prevent colon cancer. And we have a few expert speakers and survivors and advocates coming to share the experience. So to that, we have Dr. Anderson is going to give us more information.
Right.
Yes.
I'm going to give you a little information about the California Colorectal Cancer Coalition. We are a nonprofit organization dedicated to reducing suffering from colorectal cancer in all Californians. And we do this by having awareness events like this, and this is our colon that gets everyone's interest. And we also, our main effort over the past 10 years is our grants to the clinics in the state to help them increase their colorectal cancer screening rate. And over the past 10 years, we've awarded over $690,000 to 76 healthcare systems. We also work with American Cancer Society's Cancer Action Network. And we worked 2 years ago with our legislative champion. We gave him his award earlier this year during March, Colorectal Cancer Awareness Month. And it's Assembly Member Mike Gibson, and he's District 64, and he authored and passed AB 432, and this was a law that got rid of the copay if you did a fecal test and then needed the colonoscopy because it was positive, insurance companies used to be able to do surprise billing and give you the cost sharing, could be up to $1,000. He passed a law that they could no longer do that. So he was our legislative champion, and we enjoyed working with him. And so with that said, I'd like to turn it back over to Dr. Sue.
Anyway, now our next speaker is Dr. Joseph Leung. He is a professor of gastroenterology and the chair of the Division of Gastroenterology at the Mather Sacramento. And he is also my mentor, has been in town for many, many years. And as a VA, they've done a lot of work in the colon cancer prevention for the veterans. And he's here to tell us something what they are doing and they're going to do.
Good afternoon, ladies and gentlemen, and thank you, Dr. Su, for your kind introduction. And my name is Joseph Leung, as Ron mentioned. I'm currently the Chief of Gastroenterology at the VA Northern California Healthcare System. So I'm going to like to say a few words about what we're doing. I was an emeritus professor from UC Davis. I've been there for over 25 years. And I'm also the former ACG governor for Northern California. And Ron, thank you for the opportunity for me to speak on behalf of our health system. Currently, we have about over 120,000 patients in our health system, and more than 60% of the population are eligible for colorectal cancer screening, especially when recently they lowered the screening age to 45. The common methods that we do at the VA are quite simple. You know, we do the fecal test, the FIT, as Dr. Anderson mentioned, and we also do colonoscopy as a routine for screening. FIT is mainly used for younger patients who are otherwise healthy because it's easy to perform. You know, just one stool sample and mail it back, and then we can do the test. But colonoscopy is done more for patients who are a little older, more than 60, because they are more at risk of developing polyps and colon cancer. We also do diagnostic colonoscopy to investigate problems for patients such as bleeding, abdominal pain, or change in bowel habits. So we just don't do screening. We also perform diagnostic examination for our patients. Now, we offer colonoscopy at 4 sites, and most of you would know that we operate out of Mather, and we have a clinic down in Martinez and also in Redding. More recently, we acquired the Southern Tier patients, that is Stockton, Modesto, and Sonora. And so we are trying to provide service to a good part of Northern California. I'm pleased to say that, you know, in Vision 21, as part of Northern California Healthcare System, we just launched a mass FIT screening program by which we're going to mail the test kit to our patients together with a letter of explanation, and then they just mail back the test and they will process it in the laboratory. The negative test, we will inform the primary care service provider to say your patient's okay, repeat in another year if eligible. And for those who are tested positive, we will generate a GI consult for a colonoscopy, and we'll try to expedite that colonoscopy within 6 weeks of the positive diagnosis. In doing so, we try to improve our efficiency as well as improving access for those patients who are at risk of colon cancer. As we know, identifying the polyp, which are precursor, especially adenoma, is a precursor of colon cancer. And the earlier we detect the polyp or adenoma, the sooner we can remove it and prevent the adenoma and break the adenoma colon cancer sequence. Where we operate through Sacramento VA Medical Center over the last 15 years, we also pioneer a new technique of what we call water exchange colonoscopy instead of the usual air or gas insufflation colonoscopy. And for that, we were able to show in a number of randomized studies, if I could give you some brief results, that we have been more successful with completing the colonoscopy. That is, we get to the end and examine the entire colon. We also increase the overall adenoma, especially the right-sided adenoma detection rate. Now, people are concerned because of the missed right-sided lesion. Very often, they are called the precursor of the missed cancer in this population of patients. In addition, we were able to offer unsedated colonoscopy for our patient because we were able to reduce the pain. And for those patients who receive sedation medication, we were able to reduce the total amount used. And one thing we actually advocate, because patients want to control the sedation if they need it, what we call on-demand sedation. And in doing so, we have a much larger number of patients who were able to complete the examination without any sedation. So I think water exchange colonoscopy is really helping us in terms of providing a better service for our patient who's undergoing screening colonoscopy. And finally, we're offering on-demand unsedated colonoscopy. That is, if the patient knows they don't have a ride or they don't have an escort, they can come and they can have the examination done and they can drive home and not have to worry about getting a ride. So what are we doing more recently? You know, we have been trying to find better ways to detect colon cancer, and more work is being done. So we combine the use of chromoendoscopy, that is adding a dye to the water, so that we can actually improve so-called staining or highlighting the presence of these adenomas. And the most recent work that we are doing is we are doing total water exchange colonoscopy, that is no air. And this is considered a paradigm shift from the conventional or traditional way of doing air insufflation colonoscopy. So, you know, we have more data to research when we completed all the study. And thank you, Ron, for giving me the opportunity to say something on behalf of our health system. Thank you.
Thank you, Dr. Liang. And Dr. Anderson, can you introduce Ash?
Oh. One of our speakers couldn't be here today, but I want to give him thanks. He was the medical director of Covered California. They cover 1.7 million Californians, and they have 4 quality measures that they measure for 3 years. And if the health plans that they hire to take care of their patients don't increase the screening rate above the 66% national percentile, they have to give some of the premiums back to Covered California for a quality improvement fund. And so colon cancer is going to be that measure this year, the next year, and the next. So Covered California is one of our big partners in California. So Ash Abernath couldn't be here, so I'll turn it back over to Ron for the next speaker.
Our next speaker is Dr. Irvin Pike. He is our past president of the ACG, American College of Gastroenterology. He's also the past CMO of the John Muir's Center. He is the founder of the GI Quick Quality Registry and Foundation. And he is here, I just drove all the way from the Pleasanton, right?
Thank you, Ron. It's a pleasure to be here, and I really appreciate the opportunity. My comments will be brief. You know, colon cancer is a preventable cancer. As a gastroenterologist, I have received no greater pleasure than to perform a screening colonoscopy, find an adenoma, remove it with the scope, and know that I and the team I work with just prevented a case of colon cancer. It's very frustrating when someone comes in late and we discover a cancer that we could have prevented. So with that, I encourage everyone to make sure that they do get screened. Unlike a mammogram, which diagnoses breast cancer, or a PSA, which diagnoses prostate cancer, a colonoscopy diagnoses precancer and prevents cancer. For that reason, gastroenterologists throughout the country are trying to improve how they perform when performing colonoscopies. Dr. Su mentioned the GI Quick Registry, which I had the pleasure of leading the effort to develop. Over 4,500 gastroenterologists in the U.S. today submit every screening colonoscopy they perform into this registry, which immediately takes those results and measures multiple quality measures. Some of those measures are submitted to the government to help set quality metrics for all gastroenterologists. Dr. Doug Corley at Kaiser Northern California, with his team, did a study, which was published, a landmark study in 2014, that showed for every percentage point of adenoma detection performed on a screening colonoscopy, results for that physician a 3% decrease for all of his patients of the likelihood that they would develop colon cancer before the next screening exam. We went live with our GI Quick registry mid-July of 2010. So from 2011 through 2022, those 12 full years of existence of the registry, the adenoma detection rate increased from 23% to 41%. As we do the math, that's an 18% increase, 18% point increase in the detection of adenomas on a screening exam, which translates to a 54% decrease in the likelihood that a patient undergoing colonoscopy by those doctors will develop colon cancer. That's a sea change in improvement in the prevention of colon cancer. Colonoscopy remains the gold standard for preventing colon cancer and as a screening exam. As the previous speakers have mentioned, there are other screening modalities. And certainly the best modality, as they say, is the one that gets done. So please get screened. We're beginning at 45, as the other speakers have mentioned. The reason for that is there's an increase in earlier onset of colon cancer these days. It previously was for age 50. I thank you, and I appreciate it if you will tell everyone you know to get screened.
Thank you. Thank you, Dr. Pike. Now, I'm holding here an infographic form. I think you probably can get it over this one of the booths there. This is an informatic produced by the American College of Gastroenterology, and basically summarize why and what we should do about colorectal cancer. Maybe we can read briefly about that. So colon cancer is the third most common cancer in the United States. It remains as the second most common cause of cancer death. It's very common. And in the United States, every year, we are talking about 150,000 new cases and 50,000. In California, it's about 1/10 of that number. So that's why you see 5,530 flags here today to commemorate the potential death that is estimated for this year in California. So it affects both men and women almost equally. 1 in 23 men will get it in a lifetime, and 1 in 25 women will get colon cancer, and it cannot spare anybody. And the age that we start seeing polyps formation is actually in the 40s, and the peak age that we have colon cancer diagnosed in the United States is 68, and women is 72. So we do not want to wait until then. That's why the screen has to be about 10 years ahead, and that's how we started with 50 many years ago, about 30 years ago. And screening is the modality that helps us to prevent it. And in fact, over the last 20 years, the colon cancer rate decreased in the age over 50 for people who got screened. Every year, the 2 to 4% decrease. However, there's some alarming data that we have seen in the last 2 years. This is significant, that the alarming figure showing that colorectal cancer rate and trend in the younger onset and the younger age. Persons who were born around 1990 are estimated to have twice the risk of colorectal cancer and 4 times the increased risk of rectal cancer compared to those who were born around 1950. So the reason we don't know, but this is alarming. And so that's why you saw 2 years ago, the screen rate has come down from 50 to 45, and we should start screening at 45. Another figures that we have seen is that African Americans has 20% higher incidence of rate of colon cancer and 40% more likelihood of dying from colorectal cancer compared to other ethnic groups. Though there's also some disparities among racial groups. About 20% of the racial disparity in the minority is that it's attributed to the low screening rate. That's why if we increase the screening rate, we hopefully can prevent more colon cancer. And ACG, for years, have been working very hard relentlessly with Congress and legislators and lawmakers. And every year, as part of the governors, we all meet in Washington, D.C., and we meet with our representative, our assemblymen and senators to discuss about all the issues that affect us in our practice and how to benefit our patient. Now, to take home message I would like to share with everybody. Number one is do not let the barrier stop you from getting screened. Don't say that you're too busy at work, and do not say that you're too healthy to consider screening. And don't scare about the bowel prep. There are better prep that tastes nothing. You can still take it easily, and it can be done not too difficultly. And don't assume that if you have no symptoms, you will have no polyps, no cancer. We have seen too many people who claim to have no symptoms that yet come in with the cancer sitting right there. And when we recommend the age of 45, it means 45, not 65. CRC is actually preventable. And by removing the precancerous polyps, those polyps grow inside us silently. Nobody knows it's there. I cannot just read your palm and tell you a polyp. We have to put the colonoscope inside to find out. And you can see it in this big colon. Go walk in here after we finish the speeches, and you see the polyps right there. It's all enlarged. Everybody can see it. Now, as far as screening, we have the process. One-step test versus two-step test. The one step is the colonoscopy. We just do the screening right with colonoscopy. We find the polyp, remove that all in one step. If we happen to want to take the two-step process, is doing the FIT testing or sigmoidoscopy or some imaging. If that test is positive, please follow up with colonoscopy. And we all end up having a colonoscopy to remove those polyps when they're benign. And also one important point is that if we get screened early, detect even the colon cancer early, there's a 90% chance of cure. This is why we encourage screening, and please go home and spread the message that go get screened at 45. Another point, if you have high risk, like if there's somebody with hereditary disease, such as Lynch syndrome or familial adenomatous polyposis syndrome, those are hereditary disease, or strong family history of colon cancer, the screen age is earlier, and the frequency of screening is even shorter. So please talk to your doctor about that. And with that, I will stop. Now, I would like to introduce you to some advocates and two of my patients here to share the experience. And the first patient is Doug. Is here? Doug, come in. Yeah. Now, he has a lot to share with us, so let's listen to what he wants to say. Thank you, Doug, for coming.
Thank you, Dr. Sue.
Very appreciative coming. Thank you.
Thank you very much. My family's here today. My wife, Catherine, my son, Douglas, they're here today. I'm happy that they came. First time I met Dr. Sue, I was having a procedure. We met before that at online, Zoom, because of the times we were in. And it's funny, he was briefing his team on what we're going to do for the procedure. And I was also briefing the team on my history at the same time. And the anesthesiologist, he took the mask and put it over my face and said, "We're going to talk to you a little later." So it's kind of funny that right after the procedure, Dr. Sue asked me, "Are you interested to come and talk at this event?" And I told him, absolutely, for sure. I'd be absolutely privileged to come and talk to you today. So I have some information. I'll keep it brief, but I have some information about my experience. And in my experience, I'm happy to be here. I want to acknowledge some of my doctors that helped me. I had symptoms. I had symptoms of fatigue in 2010. So this is quite a long time ago. I'm a 13-year cancer survivor. In the fatigue, my doctor said, it's Dr. Paul Miller at the time, and he said you want to do a blood test and find out if there's any problem. And I found out that I had anemia, that I was only saturating about 15% of the iron, my intake. And he also said that I probably should do a fecal test. And so I did a fecal test. I told him I'm not bleeding anywhere. I have no issues. And I did the fecal test, and the microscope said yes, I was. I had blood in my fecal, in my stool. And so he said, I want to do a colonoscopy. Well, I was just turned 50 years old, and I was supposed to do it anyway, but I swore I would never do this test. And so he convinced me that this is what we have to do. So we did this test, and during the test, Dr. Chin was the doctor who did the test. Dr. Chin, William Chin, he said that he could tell that I had colon cancer during the colonoscopy. He's going to send everything for biopsy, and that's fine. And but we need to get you to a surgeon right away and have the cancer removed. And so we did that. We went to Dr. James Myers at the time. He did the colon resection, and that was great. We were able to get rid of the cancer in the colon. And then I had to follow that up with 12 sessions of chemotherapy. And so that was pretty rugged. That was kind of hard. But I survived that, and I'm here to tell you my story. I was a stage 3 colon cancer at the time, so they did catch it. I wish I would have been able to do screening sooner. And I encourage my family, because of our family history with colon cancer. My sister also had colon cancer. I encourage my family especially to get that screening done soon. So like the doctors have been telling you, if you get that screening, you can really prevent, but it's up to you. You can really prevent any issues. And I encourage you to get that done as soon as possible.
Thank you so much.
Thank you very much for sharing it.
Thank you. Thank you, Ron. I'd like to introduce Dr. Mary Beth Kropp, and she works with Fight Colon Cancer. She was on the planning group for this event, and she and Spencer, who she's going to introduce, set up almost all of these tents. And I'm quite amazed at Spencer for reasons you're going to hear about, but also his ability to raise tents. So thank you so much. Mary Beth, go ahead. Oh, Mary Beth works so hard on colon cancer because her husband unfortunately suffered and died from colon cancer. So she's made one of her life purposes is to reduce the burden of colon cancer in everyone.
Thank you. Thank you, Dr. Anderson. I speak to you today as a widow, and I want you to understand the impact that has on your family. And so I appreciate your comments. I appreciate the medical ease. But right now, the most important thing for all of us to do is become educated and aware of what happens to your body in colon cancer. So I have fortunately met some incredible people along the way. And one of them is Dr. Spencer Dayton. Spencer was born in the middle-class union household in California's Central Valley. And from an early age, his parents instilled the importance of education and standing up for what you believe in. Dr. Dayton is renowned as an expert in public policy and veterans affairs. He holds a Bachelor of Arts degree in government with an emphasis in legal studies, where he graduated, not surprisingly, magna cum laude. He has a master's in public administration with an emphasis in government and policy, not surprising, summa cum laude, and a doctor in public administration with a concentration in law and policy. He is defending his second doctoral dissertation next week on Tuesday, where his dissertation is titled Examining the Increasing Incidence in Colon Cancer in Younger Adults. At the age of 22, after a painstaking process, Dr. Dayton was given the diagnosis of colorectal cancer. After treatment, he was declared NED on April 30th, 2020. However, that fate was not pleasant. Symptoms returned, and 2 weeks before his 24th birthday, he was diagnosed with stage 4 colon cancer and it has changed his world. Today, he is in treatment and here with us today, married and working from home for the federal government. He also served as an ambassador for Fight CRC in 2021 and 2022. Spencer's accomplished more in his 6 years than many of us will ever accomplish in our lives. And for me to have the honor of learning about his journey and what we all can do to work together to bring an end to colon cancer has just been an absolute journey for me. So Spencer, thank you for being my friend, and thank you for sharing your story.
Thank you, Mary Beth. Hello, everyone. As Mary Beth said, I'm Dr. Dayton. Mr. Dayton's my father. He's a math teacher in Lodi. Don't call me Mr. Dayton. I won't turn around. It's a joke in our family household. I was 22 when I got my first diagnosis of colon cancer. And I'm going to tell you, it was a long process. I was told there was no way I had colon cancer. The doctor told me there's no way whatsoever. He did a colonoscopy, and it took me only 6 more months to get another one before another doctor told me, you definitely have cancer, you definitely had it then, and he missed it. I don't know how he missed it. Then, unfortunately, after beating it once at stage 3, it came back. I'm now considered terminal. I'm in a clinical trial. That's the only reason I am standing here today. I have chemotherapy, radiation, immunotherapy, and this clinical trial drug every 2 weeks just to be alive. And the biggest point I want to impress on anyone listening is it happens at any age. Screening's at 45, and that's way too late. I could do nothing to change and not have colon cancer. It was genetic. I have 2 gene mutations, and it turns out I probably have a third one. So that gives me a 300% chance of getting it. I'm young. I shouldn't have to deal with this. My nephew is turning 11 and will have his first colonoscopy next year because he's in my immediate family, and he has Lynch syndrome just like I do. He'll probably have colon cancer someday. At 11 years old, he has to have a colonoscopy. We can prevent this disease. 1,777 Californians will be diagnosed between now and December. 5,530. Including, unfortunately, one of those flags could be me this year. We hope not. I fight. I'm here. I do my treatments. But in reality, my wife and I, who in 2 weeks or I guess 1 week at this point, will celebrate 1 year of marriage, we have to think that that can be me. My 26-year-old wife has to think that she can become a widow just like Mary Beth. This is a preventable disease. It's your families. It's you. It's your friends. Listen, there's jokes, there's TV shows about colonoscopies and how am I going to feel, what am I going to do. If you've ever seen The Office and, Michael goes off talking about it, it doesn't matter. Do it. The worst part of the colonoscopy is the day before, let me tell you. The colonoscopy itself is pleasant. You're asleep. You don't feel anything. But it can save you. It's the only the only screening, like they said, the other doctors, that can detect the cancer before it's there. If my GI would have actually screened me earlier, when I first had symptoms, we probably could have stopped it. Yet here I am, a dying young man. Yes, I've accomplished a lot. It's because if you know me, I don't sleep and I like to get things done. But in all honesty, it's now because I don't have that much time. I'm doing everything I can because I want to live a full life. And the reality is I'm not going to. Educate yourselves. Help us. Volunteer. Even if you've never been affected, you can still be an advocate. That's what I want to leave with you today. And I appreciate those who are here and the organizations.
Thank you, Dr. Kropp and Spencer, and thank you, Ron, and all our other speakers. I think we're at the end of the formal ceremony, and so I encourage everyone to visit the colon, and look what the polyps look like. They can be removed and prevent colon cancer. We're still in the situation where 33% of Californians have not been screened, and 46% of Californians are diagnosed with colon cancer at late stage. So we've got a lot of work to do, so please help us get screened. If you have people that you know that are between the age of 45 and 80, make sure they're screened. We only have to get, if you believe the U.S. Preventive Services Task Force, which I believe in how effective colon cancer screening is, and some of the studies that have come out, and you use colon cancer screening reduces your risk of colon cancer deaths by 60%. You only have to get about 70 people on a screening program to keep one person from dying from colon cancer. So please, that's what the message is. We've got too many people in California that haven't been screened. Make sure they're screened, and we'll have a decrease in late-stage diagnosis. So Ron.
Okay, thank you very much. I thank you everybody and for coming, and also the organizers, especially Dr. Anderson. He put this up with ACG, and he does a lot more. You will see around the whole California, sometimes even to Seattle. Right? You went up there,
Yeah.
right? Yeah, and again, I was telling all the people showing up today and supporting this event. And the most important about awareness is it doesn't stop here. We should continue every day. We just want to beat this disease. Thank you.
Thank you. Enjoy it.
All right, good afternoon. My name is Nancy Schlossberg. I'm a registered nurse. I've been an endoscopy nurse for multiple years, and I'm the immediate past president of the Northern California Society of Gastroenterology Nurses and Associates. So I'm here really representing the nurses and the role of the nurse and how important they are when people get screened for colorectal cancer. We get it. We see what happens when people get screened, and we can say, great, see you in 10 years, or how terrible it is to have to be with a patient when they wake up and they go, gee, if I had only been screened on time, would you be telling me this? So it's important. The other piece that nurses do, there's a tremendous amount of yick factor, as I call it, associated with getting screened by colonoscopy. And it's so important for the nurses to be able to really talk to patients and make them understand that you can overcome the yick factor. The end product of getting screened for colorectal cancer and preventing colorectal cancer is where it's at. And my final message, and I think the nurses do this, and we hope we make the patients understand, it is important to tell your family members. It's not embarrassing. It's important that people understand their family history and when they should start getting screening and when they should follow up. Thank you.
As a patient who was diagnosed in 2019 and beat it in 2020 and then re-diagnosed in 2021 as a now terminal patient, this will kill me. It's pure awareness between social media campaigns, events, the walks, anything I can do to get people to get screened, anything I can do to get people to get information. Believe it or not, my dad was fighting colonoscopies, and once I was diagnosed, he was in within 6 months. He's going in for a second one now here for his 30th wedding anniversary. That's what my parents are getting, is matching colonoscopies on their 30th wedding anniversary. Because my cancer is genetic. So I want everyone to learn about the genetics. I do social media campaigns, I've done speeches, everything. My message here for anyone at the event is, if you're here, you're affected somehow, but there's still people who are affected in the community who aren't taking the proper steps. They're not actually getting tested themselves. They're not actually telling other people to get tested. They'll do themselves, maybe, but not their spouse or not anyone else. And it's important that we help everybody. Telling people on the street, every person who's been walking by, I did it to you, not knowing who you were. Hey, you've been tested or screened for colon cancer? And you said yes. You just tell everyone. And that's something where I think we fall short. The other thing is, we're all different organizations, but we can work together. And a lot of times we don't. So I want to see this as kind of that catalyst of working together from here on out. No more, I'm this organization and this organization. We need all of us together as survivors, patients, as caregivers, and those concerned.
Hi, I'm Irving Pike, a gastroenterologist. I am very honored to be a past president of the American College of Gastroenterology and the founding member of the GI Quality Registry, GI Quick. It's very nice to be here today and participate in this colon cancer awareness program. colon cancer is a preventable cancer, and any steps any of us can take to rid our population of this terrible disease, we should take advantage of it. Today, my message was, please get screened. The screening age is now 45. It used to be 50, but we have noticed a significant increase in early colon cancer in individuals as young or as 30 or even younger. So we have increased. Studies show that if we start at age 45, we'll detect a significant number of people who have precancerous polyps, can remove them, and by taking them out, prevent the cancer. Unlike other cancers such as breast cancer and prostate cancer, which have screenings to detect the cancer, the screening of a colonoscopy takes the polyps out and prevents the cancer. So I was very happy and pleased to be a part of this program today.
As part of our quality improvement initiative at UC Davis, we put together a project to try to increase colorectal cancer screening rates among underserved populations. Colorectal cancer is one of the leading cancers causing very high mortality rates in the country. And as part of the UC Davis program, we do want to reach out to underserved communities. So we started this project to try to educate underserved populations to get their colorectal cancer screening tests in order to try to bridge them to the appropriate screening procedures.
A bit more about the project itself. In collaboration with the leadership at the Paul Hom Free Clinic in Sacramento, we implemented a program to distribute these translated surveys, which we made with help from UC Davis Translation Services. We distributed it to patients at the Paul Hom Clinic in the language of their preference. The initial languages were Vietnamese, Chinese, and Hmong. And we distributed it to many patients over the past couple of months. We also increased distribution of FIT tests, which are one of the stool-based tests for colon cancer screening. Using all of these methods, we're hoping to increase colorectal cancer screening at this free clinic and within this underserved population. With collaboration from UC Davis itself, we won a grant for quality improvement and to help fund the rest of this program.
So we also realized the benefit of this very quickly, and so we wanted to expand the scope of our project that Sean was just mentioning. And so we increased the amount of translations that we had to a total of 10 translations. Reason being, 1 out of every 5 individuals in the United States, 1 out of every 5 households specifically, English is not their primary language. So there is clearly a benefit to having very basic resources about a very important thing such as colorectal cancer screening available not only for clinics in Sacramento but nationwide. So we're very appreciative that to be at this event to highlight this, the importance of translations here and of screening at this event. Very thankful for the organizers, and I guess the final message is very important to get screened for colon cancer.
My name's Diana. I am the practice administrator at Capital Gastroenterology. We are a gastroenterology group located in Roseville. We have 6 providers. We deal with a variety of gastrointestinal issues along with colonoscopies for screening as well. My message today is for everybody to get a screening colonoscopy, and the new age is 45 and over.
Hi, I'm Mary Beth Kropp. I am here representing Fight CRC, Fight Colorectal Cancer, and the C4. And I have been working on this effort since my husband was re-diagnosed in 2020 after really kind of a medical oops. And I'm here because it is so important not to speak medicalese, but to speak plain English to everyone, to help people understand that colon cancer is killing people. And it's not because we don't know what to do, it's because we don't know. And we have to be able to ask questions, and we have to be able to have a community. And all of these organizations that are here today need to work together and band together to raise awareness of what is happening in the colorectal cancer world. It is a totally preventable cancer. We need to do a better job at just educating people. We need to make it okay to talk about poop and bowel movements and have conversations with everyone. One of the biggest symptoms of colorectal cancer is no symptom, so we can't do anything about it if we're not aware of the things that can lead to colorectal cancer issues. My husband died of a complication just because he didn't have the proper screening of some of his organs that were damaged from a previous surgery. And it's simple little things because the medical community may not be as informed from one doctor to the next. We were blessed with a wonderful team of people at the end, but unfortunately it was too late for him. So our commitment is to, as a family, to continue to work to find solutions, to raise awareness, to educate everybody we can about the signs and symptoms of colorectal cancer, and most important, to have the courage to stand up and talk about this holistically for everyone.
Hi, I'm Selena Donahue. I'm a board member for the California Colorectal Cancer Coalition for the state of California, and here really trying to make a difference so we can help bring awareness to colorectal cancer screening.
My name is Tammy Pangelina, and I'm here with Fight CRC, Team Blue. I am here to raise awareness for colorectal cancer among our youth, from the 20-year-olds on up. I was a caregiver for my nephew Daniel, who was misdiagnosed at 27 for 2 years. First, they thought because he was so young that he had irritable bowel syndrome. Then it was Crohn's. Then it was colitis, even an appendicitis. When 2018, he was finally diagnosed, and he was at stage 3. And he went through a 14-hour surgery to remove his bladder that was riddled with cancer. He ended up having a colonostomy bag, a urostomy bag, and a fungating tumor where the tumor was growing on the outside. So I had to change all those bags. If they would have just taken the time to give him a colonoscopy, I know he would be here today. So I'm trying to get our youth that if they're feeling weird, any kind of stomach pains, go talk to your doctor. Go talk to your doctor and get checked. That's my message. I'm trying to raise awareness. It's imperative. It's on the rise. It's the second deadliest cancer among 20 to 49-year-olds. And by 2030, it's going to become the first. So please, everybody, I implore you and beg you, please get checked.
Hi, my name is Katie Beasy. I'm the director of the Folsom Sierra Endoscopy Center, and I'm here with Trish Cleff to represent the Folsom Sierra Endoscopy Center as well as the Gastroenterology Medical Clinic in Folsom, California. We're here and excited to celebrate Dr. Sue as well as support him in his Colon Cancer Awareness Month. And we are excited. Get your screening at 45.
45 is a new 50. Come on down for your appointment.
My name is Joseph Leung, and I'm the Chief of Gastroenterology for the VA Northern California Healthcare System. I'm an emeritus professor. I retired from UC Davis recently, and I'm also the former ACG governor for Northern California. Today I represent the VA to present some information regarding how we take care of our veterans. I'm based off at Sacramento VA Medical Center, and altogether we serve about 120,000 population in our catchment area. We operated through 4 sites at Mather, Martinez, Redding, and more recently we take care of the southern tier patient, mainly Stockton, Modesto, and Sonora, and we base ourselves through the Stockton Clinic. Today I actually want to discuss about the colorectal cancer screening program for our veterans. We just recently launched a mass screening program by mailing our patients who are eligible for screening the FIT or the stool test, together with an explanation letter explaining that if they complete the test, send it back to our lab, we will follow up with the results. For negative tests, we will inform the patient they are good for at least a year, and we inform the primary care provider. For those tested positive, we will try to expedite a diagnostic colonoscopy within 6 weeks to make sure we don't miss any underlying pathology. In doing so, we try to improve our efficiency as well as access for patients who are at high risk for colon cancer so that we can get to them in a timely manner. At the same time, I also want to introduce what we have done over the Sacramento VA Medical Center for the last 15 years. We introduced the concept of water exchange colonoscopy. This is different to the conventional air insufflation or gas insufflation colonoscopy, in which that we use water to go in and then air to come out, in short. The result shows that we can actually improve the preparation. We increase our success rate in completing the colonoscopy compared to the air colonoscopy. But more importantly, we were able to find more adenomas, as well as adenomas on the right side of the colon, which are known to be the precursors of missed colon cancer in the colon. Another aspect of water colonoscopy we felt as an advantage is that we are able to reduce the sedation medication for our patients, because it's not as painful, so to speak. And we were able to complete unsedated colonoscopy for some of our veterans because they don't have a ride or an escort. And in the essence of patient-centered care, we offer the patient what we call the on-demand sedation. That is, patient control the medication needs. They will give the medication if they say they want it. And as a result, we were able to increase the total number of patients who completed an unsedated colonoscopy compared to the air method. We have also looked into methods to further improve the outcome by combining a dye staining method or chromoendoscopy, and we were able to find more precursor or the sessile serrated adenomas on the right colon when we use the combined dye and water exchange method compared to the conventional air colonoscopy. And more recently, we are looking into using total exchange water colonoscopy, that is no air in the examination. And this is considered a paradigm shift compared to the conventional air insufflation colonoscopy. And we felt that it will improve patient discomfort, and certainly we felt that it will improve the clinical outcome in terms of adenoma detection. And we have plans to continue with more clinical studies.
I'm Dr. Stoney Anderson. I'm a retired gastroenterologist. I'm the president of the California Colorectal Cancer Coalition. We've been around about 16 years. Our main job is to increase screening in Californians and to reduce the suffering from colon cancer in Californians. And so we do this in a variety of ways. One way was what you've seen today, an awareness event where we have the blow-up colon that people can go through and see how polyps can progress to cancer, and that you can get any one of the screening tests, that all the screening tests find polyps, and then you have to have a colonoscopy that removes the polyps. And the tragedy is, of course, that we still have 5,530 Californians that are dying from colorectal cancer. And one of the main reasons is that only 66% of Californians are screened for colon cancer, and about 46% of the colon cancers that are diagnosed are at late stage. So we need to do better. We need to have more people screened. And one of the things that C4 does is we raise money. We're a not-for-profit organization. We have all volunteers. We don't have any paid employees. So the money we raise, we give back to the federally qualified health centers, because their screening rate in California is only about 46%. We give them money to increase their screening rates, and we've been doing this for 10 years, and we've given over $680,000 to 76 of these clinics to help them increase their screening rates, and we've been able to watch as they increase their screening rates. So that's what we do. We also do advocacy. We were able to work with Assembly Member Mike Gibson to pass AB 342, which removed cost sharing after a positive fit. If you get the colonoscopy, they used to be able to charge you cost sharing or a copay. Now they cannot, so we do that. Our efforts to do that resulted in nationally for this becoming the rule, that no insurance company in the country can charge cost sharing for the colonoscopy after a positive non-colonoscopic test, which is usually a FIT test or Cologuard. And the other thing we did, which was interesting, we found out that Medicaid does not measure colorectal cancer screening. and did not measure it, and they had some of the lowest rates of colon cancer screening in the country. And in California, we didn't even know what their screening rate was. So we had to work with the Centers for Medicaid and Medi-Cal to make the Medicaid quality measures add colorectal cancer screening. And we were able to do that a year and a half ago, so that in 2022, for the first time, colorectal cancer screening is being measured in the Medi-Cal population. And we expect those measures to be out mid this year, 2023. So we'll see, and we'll find out which insurance companies that insure the Medi-Cal population are doing poorly, and then we'll help them improve, because it'll save lives. So our main idea is to make sure that Californians' lives are saved and they don't die from colorectal cancer.
Hello, I'm Dr. Ronald Siu. I'm current governor for Northern California of the American College of Gastroenterology. Today we are here in Sacramento at the state capitol for the colon cancer awareness Light the Capitol Blue event. The goal is to raise awareness of colorectal cancer and how preventable, how beatable it is. Today we have inflatable colon where our attendees can walk through and understand what's inside the colon so that they are aware of what polyps and cancer could look like. And then after coming to this event, we hope that they will bring the message home to raise the importance of screening, because screening can prevent colon cancer, and it is important that we start early. We do not want to wait, and in screening we can detect colon cancer early, and then we can have a 90% cure. For screening, we have two steps. Sometimes people do a one-step test, which is the gold standard colonoscopy. We can do colonoscopy in one go and detect and find the polyps and remove them. However, there's also a screening test using stool or sigmoidoscopy or imaging test. And if we go through that route, once the test is positive, it is very, very important to go through a colonoscopy to find the polyps and remove them. And since 2021, the screen age is now 45, so it's important to start screening at a younger age.